Children can get arthritis as part of an acute illness, like a viral illness or after a strep infection, or they can get arthritis that's more chronic. Chronic arthritis in childhood is called juvenile idiopathic arthritis. Juvenile idiopathic arthritis is defined as arthritis occurring in a child before their 16th birthday that lasts for 6 weeks or longer. And it's differentiated into 7 subtypes. And the subtypes are defined by either how many joints are involved, fewer than 4 joints or more than 4 joints, whether the child has a rash called psoriasis, or whether there's the presence of features like fever or rash or other internal organ problems. It's very helpful to define which subtype of juvenile idiopathic arthritis a child has. First of all, medication decisions may be guided by knowing which subtype the child has, because some children may respond better to certain types of medications rather than others. In addition, it's often helpful for parents because it may help them understand what the longer-term outcomes for their child will be. And lastly, it's important to understand exactly what subtype a child belongs into, because we need to rule out other forms of arthritis before we can say it's juvenile idiopathic arthritis. First of all, children are not just little adults. They don't have rheumatoid arthritis, and that's a common myth that we hear. Some of the subtypes of juvenile idiopathic arthritis are rarely seen in adults, such as oligoarthritis. Only about 5% of children with juvenile idiopathic arthritis have a form of arthritis that's similar to adult rheumatoid arthritis. So that's one of the first myths. Secondly, commonly we hear people say that children will grow out of their arthritis, and this just isn't true. We have good information that tells us that at least 60% or more of children that have juvenile idiopathic arthritis will continue to have arthritis into adulthood, or will have problems that result from having had juvenile arthritis. So in essence, they don't generally grow out of it. And lastly, often parents, when their child is seen to have arthritis, are told by people that this is a minor problem, it's not a major problem. And this is also not true for many children with arthritis. Most children with arthritis suffer pain, disability, and difficulty participating in normal activities every day. And some children have very severe disease and are really quite limited, are required to take daily medications, or even require injections, either on a daily basis, a weekly basis, or a monthly basis. So juvenile idiopathic arthritis is not really a minor problem for those children. The important fact to remember is that children and teenagers with arthritis are really best treated by a team of pediatric rheumatology specialists, and that would include a pediatric rheumatologist and a nurse, physiotherapists, social workers, and occupational therapists who are trained to help children with arthritis and their families. Juvenile idiopathic arthritis is diagnosed by a physical examination and taking a history. So one important key fact to remember is there is no blood test that tells you whether your child has juvenile idiopathic arthritis or not. A full examination of all of the joints of a child suffering from joint pain is necessary to find out which one of them may be involved. Additionally, the doctor will take a history that's specifically focused on finding out how long pain has been present, whether there's joint stiffness, but also how these problems are interfering with the child's activity. In addition, they will ask questions about whether other features have been present, fevers, rashes, or other problems. Blood tests, again, are helpful in understanding the subtype of arthritis, but don't tell us whether a child has arthritis or not. Lastly, X-rays are not helpful in determining whether a child has arthritis or not. Early in the course of disease, we rarely see any changes on the X-rays, so they're not helpful in making the diagnosis. Early diagnosis is really critical for children with juvenile idiopathic arthritis. And the reason is because the sooner we start treatment, the less inflammation occurs and the less chance of damage and permanent disability. Most children with juvenile idiopathic arthritis will be treated with non-steroidal anti-inflammatory drugs early in disease, and these medications help with pain and stiffness. Frequently, if these are not effective enough in controlling inflammation and a child has inflammation in one joint, such as the knee, we might use an intra-articular injection of steroids into the joint to settle down the inflammation. Many children with arthritis who do not respond to non-steroidal anti-inflammatory drugs early in their disease are prescribed what we call disease-modifying agents. These are the same types of medications that are used to treat adults with rheumatoid arthritis. The most common disease-modifying agent that's used in children with arthritis is methotrexate, and this is also commonly used in adults with rheumatoid arthritis. Nowadays, we also progress on to using the newer biologic agents to treat children with arthritis who don't have an adequate response to standard therapy, which would include disease-modifying agents. We know that with early and aggressive therapy of children with juvenile arthritis, that 60% of children may go into having inactive disease within 6 to 12 months after diagnosis. Children with arthritis have several kinds of problems that may not be seen in adults with arthritis. Firstly, children are growing and developing. And when children who are growing and developing develop arthritis during that time period, it can affect their eventual development. For example, if a child has arthritis in one knee and not the other knee, they may suffer a discrepancy in their leg lengths as they're growing if the disease is not fully controlled. Those kinds of leg length discrepancies and other growth disturbances can lead to permanent deformities, which will require orthopedic or other types of treatment. Secondly, there are some consequences of juvenile idiopathic arthritis that are not seen in adults with rheumatoid arthritis. A certain percentage of children with juvenile idiopathic arthritis suffer from idiopathic eye inflammation called uveitis. Uveitis can be very severe and in fact can cause permanent visual damage or even blindness if it's not detected and treated early. The difficulty is that children with uveitis don't have symptoms, so they don't have a painful red eye. They require going to the eye doctor on a regular basis for screening to have their eye inflammation picked up. If it's picked up early, it's easily treated with drops and other treatments. So this is very, very important. Lastly, children need to be able to participate fully at home, in their community, and at school with friends in physical activity, in community types of sports, in order to develop into healthy adults. And it's important for children with juvenile idiopathic arthritis to have assessments that promote their full activity at home and in school. And this is quite different from the treatment for adults. Well, as anybody who is a parent and has teenagers know, dealing with teenagers can be challenging. And this is no different in the pediatric clinic. We start to address the issue of children moving on to adult rheumatology care quite early in children's care, when they're early in their teenage years. This is something that's quite different from adult rheumatology care. We start to see children on their own in the pediatric rheumatology clinic for short periods of time during their visits, without their parents in the room. This allows the child who's age 13, 14, or 15 to learn how to talk to the doctor and the nurse on their own without their parents there. And it also allows us to talk about issues that they may want to ask us confidentially. This might include issues around experimental behavior with drinking or sexual activity. Once children are getting to the age where they are transitioning out of high school out of the pediatric setting, plans are made for children to move on either to a special transition clinic or to adult rheumatologists. There are a number of places across Canada where there are special, what we call transition clinics for young adults with rheumatic diseases to receive care. These young adults between the ages of 18 and about 22 will be seen in those clinics on their own, and the focus is around promoting being able to be independent in your health care. There are transition clinics that are active in Vancouver, in Saskatoon, in Halifax, and in other centers across the country. The easiest way to find other families that are sharing your experiences is generally through the pediatric rheumatology team. Pediatric rheumatology nurses can often connect parents to other parents whose children have similar diseases or similar concerns. Other ways that parents can get support and meet other families might be through a family education day, which some centers across the country offer. Children can go to camp. In a number of centers across Canada, there are pediatric rheumatology camps set up for children to attend where they can meet other kids who have similar diseases and make friends and have fun. Ask your nurse or doctor for reliable websites that might be helpful for you to access other parents or get information. And lastly, it's often helpful to access other organizations like the Arthritis Society or parent organizations set up like Cassie and Friends. Cassie and Friends is a group in BC set up by parents to bring parents together both to fundraise and also to provide support around developing programs for kids with arthritis.